Thank you for joining this community information session, Bowel Management for Adults with Spina Bifida. Bowel incontinence is one of the most impactful issues that people with spina bifida face and was identified as such in SBA's community-centered research agenda. We are grateful for our sponsors of this session, Atinas, Hygiene, WellSpect, and Coloplast. My name is Judy Thibodeau, and I'm a member of SBA staff. I'm joined by my colleague, Juanita Panliner, SBA's National Resource Manager. I want to mention a few things before we get started. You will remain muted throughout the session. You're welcome to submit questions using the Q&A feature on Zoom. If time allows, the speakers will respond to the questions. Everyone who registered for this event will receive a link to the recording. Closed captioning is enabled. If you have any technical issues, please send a text to Juanita Panliner, 202-487-3988. This section is being recorded. There will be an Ask the Expert session next week, Thursday, September 26th at 7 p.m., which will provide an opportunity for you to pose your questions to these experts. You must register for the session and may submit your questions at that time. Now, I'm pleased to introduce the speakers for tonight's event. Dr. Mary Ellen Kelly is an assistant professor at Duke University and has been a pediatric nurse practitioner in urology since 2010. Dr. Joy Kerr is a pediatric nurse practitioner who has specialized in pediatric urology for over 20 years and has consistently cared for people with spina bifida. Over the last 9 years, she has focused her practice on the spina bifida patient population, specifically neurogenic bladder and neurogenic bowel dysfunction. Doctors Kelly and Kerr were members of the Lifespan Bowel Management Protocol Development Team. Courtney Daly is an adult with spina bifida and a mental health therapist who lives in the suburbs outside Chicago. Courtney received a master's degree in counseling psychology in 2018. Courtney brings her lived experience to this discussion. Please join me in welcome Mary Ellen, Joy, and Courtney. Mary Ellen?
Thank you, Judy. All right, we are happy to have everybody here and are very happy this is getting recorded for anybody who is not on. So I'm kicking us off tonight. I apologize, I gotta move my bar over. So I wanted to just start by what we know about adults with spina bifida and neurogenic bowel. We know that we have failed. Unfortunately, pretty much everybody age 20 and over, who are probably all of you on this call, on this webinar, generally this was not a focus of spina bifida treatment. There were inventions such as, the VP shunts and catheters and things that really helped to increase the lifespan for individuals with spina bifida so that now it really matches and parallels the rest of the population. And because of that, we're now shifting our focus and working on bowels. So on behalf of all clinicians, we have failed. We are trying now. We want to do better in this realm. We're doing better, I think, with pediatric children, but we're now reaching back out to the adults that we have missed. And that is me admitting the mistakes of all of us who have come before me and my generation of clinicians and are working to not repeat this as we move forward. We also know that only about 45% of individuals with spina bifida are continent of their bowels. This is a pretty dismal number, and we know we need to, again, just do better. We also know that those who are older than age 20 are known to have worse continence rates above this 45% compared to people below age 20. We also know it's hard to find clinicians as an adult who will treat neurogenic bowel or really understand it well. And there are only 25 adult clinics currently in the country who offer care to spina bifida patients. So I want to make sure we're kind of all on the same page as we talk about this. So I want to just kind of bring us back to maybe your elementary or high school science classes about biology. But just kind of this is how your bowel might be functioning and really what the differences are between a typical bowel and a neurogenic bowel. So this is kind of just general shape of your bowel. When we talk about things, we have the appendix, which is the what can get infected and give you appendicitis when people get sick, but it's also what we'll sometimes use to create a MACE or an antegrade enema, antegrade continence enema channel to the abdomen to allow for a catheterizable channel into your bowels. Then we have your ascending colon coming up, then across your abdomen, moving from your right to your left is your transverse colon. This is called the splenic flexure right here. You kind of curve down, and this is now your descending colon running down your left side, kind of loops behind your bladder. It's the sigmoid colon into the rectum, and then the anus to the toilet, to the pull-up, to wherever the outside of your body is. So the typical function, as processed food and the waste product moves from your small intestines into your large intestine right here over on your lower right quadrant of your abdomen, water is absorbed. That is the primary function of the large intestine. Now, what's different about a neurogenic bowel is that the water can be absorbed differently. So generally, this means the water is absorbed either faster or slower in somebody with a neurogenic bowel. So it gives your stool a different consistency than someone else's. Again, in kind of a typical fashion and typical function, the stool then moves, again, in this kind of on the screen clockwise fashion, by a uniform peristalsis. So something squeezing from one side, causing the next segment to squeeze, the next segment to squeeze, and so on in a nice uniform motion. I like to say this is, my example is somebody uses a tube of toothpaste, and you're really good at using it, and you always squeeze it from one end, and you keep squeezing it and keep squeezing it until it comes out. That's kind of how a typical bowel should function and move stool. Now, somebody with neurogenic bowel may have a difference here where that peristalsis, that movement is disturbed. So usually it's more sporadic. So if you think of that tube of toothpaste, instead of just squeezing from one side the whole time, someone grabs it in the middle, someone grabs it at the end, someone grabs it close to the outlet. It kind of contracts or squeezes, not in a uniform way. It also doesn't necessarily do it at times you would expect. In a typical fashion, you get the most peristalsis after a large meal, but someone with neurogenic bowel might not. So you kind of get stool that's harder or softer, and it's kind of being squeezed on one end, squeezed on another, squeezed somewhere else. You're not getting that nice movement to get things kind of in a uniform fashion over into the rectum and then to the anus. This is kind of one of the last phases of how you would normally have a bowel movement in a typical bowel. As the stool starts to move down into the rectum, it starts to fill the rectum. And the rectum actually stretches, and there's stretch receptors. So something there that really senses that stretch, sends a signal up to your brain that says, ooh, there's something here. There are contents here. I need to relax and go find a restroom. And then you have a voluntary relaxation of the external anal sphincters, and you can expel the stool. Okay, so it's fullness that causes a reaction in the brain, a sensation in the brain that then gives you the ability to realize I need to voluntarily relax my anal sphincter. Again, in neurogenic bowel, and we know there's so many different ways this can manifest, but generally there is a lack or a very diminished sensation of that rectal fullness. So it'll just fill and fill and fill, not sending signals to the brain because of the disruption in the nerves. And then oftentimes the rectal sphincters are not under voluntary control. So they tend to be a little bit more, we say, gaping or open. They're just relaxed. Kind of at any time. And then if you imagine there's a force behind it, that's when we end up with incontinence. Okay, so that was my biology 101 lesson, just to make sure we kind of understand how and why neurogenic bowel happens and why it happens so commonly in the spina bifida population. The next thing I'm just going to spend a few minutes on is going over a survey that we actually recently completed. This was a partnership with the Spina Bifida Association, Duke University, where I'm at, and the University of Alabama in Birmingham, and then you, adults with spina bifida. So we appreciate all of you who were able to participate in this survey, and I did want to take a minute to share some of those results because we were really trying to figure out where adults with spina bifida are currently getting their bowel management care. So there were 154 surveys that we did receive back, and you'll see that we had a pretty good range of individuals who completed it age-wise, with the majority of individuals being of age 35 to 44 who completed this survey. We had a nice split, a representation of people who identified as men, women, and non-binary. Similarly, this was our distribution of individuals who self-identified their race categories as white, Black, Asian, or other. And thankfully, we got representation from around the whole country, which was great. So we feel like this was a pretty good sample. So 113 out of the 154 total people who completed the survey stated that they attended a spina bifida clinic in childhood, and 35% continued to attend a spina bifida clinic into their adulthood. 63% did not have bowel continence care during their transition into adulthood. So again, this kind of points back to the fact that we know we weren't doing well. We did not make this part of the transition into adult care. These are some of the common issues, which you guys are very well versed with. We know it's very hard to find a provider, and greater than 50% of you pointed out that. Additionally, we did see most people are self-managing their bowels. And as far as kind of who's helping to decide, should I add this or subtract this? What else should I do with my bowels? The education on how to manage them was 62% of people were saying that's still coming from a healthcare provider. And a third of individuals said it's coming from the SBA. And about another third said you're getting this from the social media, so things like Facebook. As far as what people were doing, there was a bit of a difference between those. This is the regimen somebody was already on now as an adult. There was a bit of a difference whether or not you were still attending a spina bifida specific clinic or not. So those with the blue were still attending a spina bifida clinic. So this was a lot of individuals who now have pouch fecal diversions or colostomies. And a lot of the individuals who are not attending clinics don't currently have a bowel regimen. And again, I just kind of wanted to highlight this again. We understand there's a real lack in who can help to manage your bowels. There's a lot of individuals who are still using primary care specialists as opposed to somebody who's really well versed in treating neurogenic bowel. And there's a lot of people who are self-treating, maybe using information from the SBA, your peers, social media to help do that. We did notice there was a difference in the individuals who were still having a lot of incontinence versus those who were not, and where they were seeking care. And with that, I think I turn over to Joy, who's going to take us a little further.
Well, good evening. It's really nice to be here and to join Mary Ellen and Courtney and Judy and Juanita tonight. I just want to talk a little bit about the definition of constipation. And so we spent a lot of time as a group trying to define this for our patients. And so what we feel like there are signs that the bowel's working well, they're positive, and there are negative signs. And the positive signs are that your appetite is good, you have appropriate, your weight is stable, probably as an adult more than weight gain. We worry about weight gain in children. The stool is creamy or mushy. It's not hard like pellets, and there are no acute changes to stooling patterns. Like 1 minute I have a more soft stool, the next minute I'm having hard stool, then I'm having diarrhea. Any of those types of really abrupt changes are things that we get concerned about. So if you're not having that, that's actually good. That's more stable. But signs, negative signs include abdominal distension, where you just have a lot of gas. You feel miserable from it. You're not eating well. You don't feel like there's room in there for more, anything, because it's just too full. Those changes in the stooling pattern or in the consistency of the stool. And we have a stool chart. It's called the Bristol stool chart that we use. And 1s and 2s are more of those hard nugget types of stools that just kind of sneak out when you least expect them. Anytime you have to strain to have a bowel movement, or if your stool is really liquidy, bubbly, grainy, any vomiting is definitely a very concerning sign. It can also be a sign of a UTI. And blood in the stool is very concerning, and increase in urinary tract infections, because we know that when our patients are constipated, that is what puts them at risk for becoming, just having a lot of really good bacteria in the colon that is just hanging out there and multiplying like crazy. And so we have like this overgrowth of good bacteria that then is one of the causes of why our patients get UTIs. Next slide. So we came up with a list of interventions, least invasive to most invasive. And so we always start with oral medications. If you're having hard stools, we want to try to get things either soft, but we also want them moving, right? Because the longer the stool sits in that colon, like Mary Ellen said, the more water is absorbed, the harder the stool gets, right? So we really want to make sure that stool is moving as well as staying softer, on the softer side. So things like Miralax, lactulose, even Linzess, those types of medications are things that help things not only move, but also add fluid or pull fluid into the stool. Things like Senna help move things along. And so that's more of a stimulant. And for some people, digital rectal stimulation, just using a finger, is enough to keep things, get things started and moving. Suppositories like glycerin suppositories, enemies, those mini enemies, they're really nice for some people and they work very well. More the liquid suppositories than a hard suppository that looks more like a bullet. Some enemas, some people do very well with a fleet enema, but we really don't recommend those on a regular basis. We prefer to use either water or saline. And so for many of our patients, the first true enema that we ever use is called a cone enema, which is a more large volume enema. For some patients, it might be a balloon catheter, like a Foley catheter that has a big balloon, a 30 cc balloon that we can blow up and occlude the outlet. So these particular systems for doing anything from below or per rectum, as we would call it in the medical world, we have to find a way to occlude the outlet, because we know that the anal sphincter tone is also affected by spina bifida. And so I have patients that and when I examine my patient, it looks nice and tight. And the mom's like, yeah, well, that's what it looks like now. But in 10 minutes from now, it's going to be wide open again. And so it's very unpredictable when that anal sphincter is going to open. And so we need something that can occlude that outlet and get the fluid in, and then help to wash out any stool that's in that descending part of the colon, the sigmoid colon, the rectum, and then out through the anus. So these are more large volume. There are some transanal irrigation systems we'll talk about, antegrade enemas that Mary Ellen spoke about, and then colostomies. So we're going to review some of those things as well. So, how to get started or change. You are not too old and it is never too late. And I think that's really an important thing to remember. If you desire to have a good bowel program, if you are at a point where you're saying, I'm limited in my social activities and my family life because I can't leave the house without having an accident or things like that. We want you to have a good bowel program that really works for you, that gives you that freedom, that you don't feel like you have to stop everything and change because of this problem. So one of the most important things that I find is really helpful, and I have families that are really good at it. I have a couple of families who send me these Excel spreadsheets of, this is what irrigation fluid, how much, the exact time it was done, how long it took, and then, what the outcome was, what did the stool look like when it came out. And then the next thing is they have a different color code for they had soiling, and it was this consistency, and this is when it happened. And it was associated with, we ate too much ice cream, or we had fried foods for dinner. So things, and for some patients, it's more exercise. It just depends. So trying to have an idea of why you're having accidents, the best way to track it is to keep a diary. And so a 3-day diary is really, really helpful to any of your providers that are going to be managing your bowels. So bowel cleanouts. They're very useful. They really can help improve the success of starting a bowel program. If you can get a good bowel cleanout before you start any type of program. So we admit that they are not pleasant and they may bring up some bad memories. I have some bad memories from my recent colonoscopy. And we want to find the right one for you. So I would tell you that most of my patients who have spina bifida, if I just do an oral medication, like I give you a lot of Miralax, if you're really backed up with stool, that could take days for it to work and for it to finally come through. And that's very unpredictable. And so I typically find that if I can do something like a larger volume cone enema from below first, clean out what I can, and then give you the oral medication, that we're going to see that move through a little bit faster. And so your provider is going to do things that really make sense because of the experiences that they've had with other patients. And we want to make sure that when you have it, you're not going 7 days and waiting for this, and then all of a sudden it comes through. So we want to find the right one for you. So enemas are what we're going to be talking about next. I talked about the oral medications, the digital rectal stim, and the suppositories like enemies. So the cone enema it's available through DME companies, but it can also be ordered through Amazon. And if you really clean it and you leave it open and air it out, I mean, people can use them for wash and reuse them for up to 6 months or more. And this is one of the most affordable ways to do a bowel program. It can, however, be a little bit challenging depending on your ability to balance on the toilet. Using your, you really need to be able to lean forward. And for a lot of my patients, what they have to do is they have to go between their legs. It makes sense to say, well, I'm going to go from behind, but then I've got to lean to a side. I've got to have something to lean on, like maybe an over the toilet commode or a rail if you have one in your bathroom, so that I can put it in place. I've got to be able to have my feet on the floor to balance myself. And then I have to have the strength to hold it in while the fluid is going in. So there's a lot that goes on with this. It can be used either on a toilet or a commode. And for a lot of my patients, they have an over toilet commode, so they're just using the commode part of it for the stability that they need. And this is a very good product. We usually use about 500 cc's to start with. I don't ever go above 1,000 cc's in these. And most people really can't tolerate more than 500 cc's of just, people use many fluids, and we can talk about that. There's warm water. Some people use saline. Some people use a lot of additives like glycerin, Castile soap, baby shampoo. There are options, and there are recipes that we all have in our arsenal of things that we use to try to get things moving, but just so that you're aware of that. So we'll look at the next one. So there's a new device called Aquaflush. It's very similar to the cone. However, it comes with a pump, so you're not dependent on gravity. So the cone system is simply a bag. It's got a roller clamp. We're dependent on the gravity to get it in. The other thing about the cone enema I didn't mention is that there's only, and you can't see it on the picture really, but there's only one hole, and it's at the very tip of it. So if there's hard stool sitting there and you're pushing the cone into the hard stool, it can be a little messy, because that's like putting your finger over a hose, right? And so that it may come backwards and drip out. So the Aquaflush is a really nice option. It's one of the least expensive of the three pumped type of enema systems. It is a cone, but it has 3 holes. So there is a hole at the tip and there are holes on either side. Gives you a lot better chance of getting fluid in, even if there's hard stool inside the rectum. These are also able to be washed and reused. I will tell you that the cone tips are meant to be thrown out by the company, but they are the most sturdy cones ever. And a lot of my patients just reuse them until they just say, okay, this one is ready now. And they use them for months. So also can be used on the toilet or on the commode. It is a lot more affordable if insurance doesn't cover for this type of a system. The next system, we call these transanal irrigation systems. And the last one was too, but I really do think it's kind of in a class by itself. These are different because they use a catheter. So they use a catheter that has a balloon that inflates. So what you're doing is it's the same thing. You have a pump system. You're not dependent on gravity. So you get better fluid in, higher up into that descending colon. And it really works very nicely to really help the colon move things through the system. Now, the difference, they're not very different in the way that they work, but they both have a balloon on the end that inflates and occludes that outlet so that we can just, not have any backflow. And once you're done, you deflate and let it all run out. I have a number of patients on both of these systems. And this is one of the ones that I really think is helpful for patients who want to be independent with their bowel management, because many patients can become very independent with using this. And it works very well. Many of my older kids, I would say that the teenagers who are using this are often using it every other day and not having to use it daily. And they're getting really good outcomes and they're staying clean. And that's really helpful. It is a little cost prohibitive if you have to pay out of pocket for either of these. They're both expensive. And so it's very frustrating when we've had patients on it in their pediatric years. And then when they become an adult and get different insurance, they can no longer afford this because it's not being covered by their insurance. But I want to reassure you that we're all working hard, especially Mary Ellen and Judy, on getting coverage and getting Medicare to really work on, this is an important device for our patients and their families. And so they're working really hard. The SBA is working very hard on being proactive and getting this covered. So Mary Ellen talked a little bit about the MACE. This is called a Chait cecostomy. This is a little catheter that is placed. Now, it is what we call a pigtail catheter. You can see the little curlicues in it. When we insert that catheter, it is straightened out. It's on a specific type of a thing, and it goes in straight. This can go in through an interventional radiology procedure or a surgical procedure. I know that in my practice, I have in the adult world, I have people at Penn Medicine next door who will put these in, and I have somebody in one of my North Jersey. His son is one of our patients, and so he's an interventional radiologist in North Jersey, and so he has agreed to take care of these types of tubes for us and for our patients specifically. Again, difficulty exists in finding a surgeon so you can find people to put them in. It's really the management that I think is the hard part. Finding people who are willing to tell you and help you troubleshoot when there are problems with this device. And so I have a patient who had one in and he woke up and it was halfway out, and so he calls me and I'm on vacation. And these are the things that they come with a little bit of, concerning things that happen, and they do need to be replaced. Now, I think we used to say 6 months, every 6 months, but I think people are using the same one up to a year. As long as it's being consistently flushed through, I think these work really well. And you can, go up to 9 to 6 months sometime, or 9 to 12 months with these. But they do need to be exchanged in an IR, interventional radiology suite. All right. And then the next one is, so I think, Mary Ellen, if we can go back to that other, I'm sorry, you talked a little bit about a MACE procedure. And so a MACE procedure is when we take that appendix and we actually oversew it into the colon a little bit to create a little bit of what we would call, we want to create a little resistance, but we want to be able to pass a catheter through it. And then we bring the end of it out into the same site where that little tube is. And it's something where you can actually pass a catheter through and there's nothing on the outside. And I think that's a really nice option. The thing with those is that, what we have found is some people stop using them for different reasons, but it does matter how, your appendix is only so long, it's not going to grow. And so as we become a little in our older ages, have a little more adipose tissue in that abdominal wall, that can sometimes cause there to be strictures and different things that prevent you from passing that catheter. And so one of the surgeons that I have in my practice really will make an assessment of the abdominal wall, and he will ask patients to, this is my adult surgeon that I work with, he will ask patients to work on weight loss and come back in 6 months, and then he'll reassess before he's willing to do the surgery. And so just another consideration about that type of procedure. And then finally, colostomies. So I was an operating room nurse for many, many years before I became a urology nurse and a nurse practitioner. And I would say to you that in the past, we often felt that, if we had to do a colostomy, that was just a fail on our part. But I would say to you that when we speak to patients and families who have decided to opt for this, that for them, it's really a lot of freedom. And so it really depends on where you are and what you want. If I just want to stop having, sores on my bottom, if you want to stop, because I'm soiling or because I'm sitting a lot, those types of things, this might be a great option for you. And we've decided, what, this is a really viable option for the right patient. And the person who really is like, this is something that's easy to exchange. It's right on your belly. You can pull the bag off, empty it out, and clean it out if you want, or just get a new one and put it on and throw that one in the trash. So for some patients, this is really a good option for them. So I'm going to pass on to Courtney here. So Courtney, it's all for you.
Hello. So I'm an adult with Spina Bifida. I'm 36 years old. And I have had a MACE procedure since I was 10. And so some considerations, I know that we are lacking in the area of, bowel management for adults, but hopefully we are on our way to help fixing that. Some considerations for adults for bowel management, for women specifically, it is very, very common to have menstruation when we do have our periods, to have increased loose stools. So that can also mean that if you don't have a bowel management program, that it's really, really unpredictable. You might have to miss work, you might have to miss school, you might have to miss out on social engagements. It is also really important to, if you're a woman, to also realize that pregnancy can also impact your bowel management. And if you have any issues with bowel management before you do decide to get pregnant, or have any fertility conversations, it's probably a good idea to consult with your providers who manage your bowel management, to see what things could come up for issues, related to pregnancy. Let's go to the next slide. So another consideration for adults is we all have to talk about sex, right? We don't talk about it enough, and it needs to absolutely be a topic of conversation. I know for myself, I've had a MACE since I was 10, so my bowel management has been pretty well under control, and I was really fortunate enough for that. And so dating and socializing and doing the things that quote unquote normal teenagers or anybody does experience, right? Bowel management was a huge reason for my success in that area. When it comes to having a normal sexual relationship with a partner, incontinence is absolutely the number one. And this is anecdotally speaking. I can't speak for everybody, but having incontinence is a huge factor for social and intimacy issues. And so we have to talk about having, a trusted partner. We have to talk about having, a backup plan. What if something is to happen? Do we have all of the things that are available to us? And let's make sure that we're having open and honest communication about it, because these are things that we are going to experience. So, let's see. We have all of we're going to talk about well, of course, you are beautifully and wonderfully made. The nerves and reflexes for the bowel and bladder and sexual function, they're all really, really close together. So all of these things really do impact our sexual health, our sexual well-being, all of those things. So if we don't have a good, bladder management, for women specifically, increased UTIs if you're sexually active. So we have to make sure that we are emptying our bladders. We have to make sure that if we are on a bowel program, that maybe do we figure out that we have to do it before or after we're intimate? These are all really important things to consider. And when we do have spina bifida, it's really, things are hit and miss, right? Our nerves aren't connecting to our brains, and our bodies at the same time. So if you are in an intimate situation, well, sometimes things happen, and you have to be comfortable enough to have a backup plan. We make sure that we have access to things to clean it up. We also make sure that we just have an open conversation about it, and we make sure that we are honest. And everybody poops. Everybody has an accident. It happens. It's life. So I myself am a mental health therapist. And so I remember when, before I had the MACE, my mental health was not good. I didn't have friends. I was 10. I was 10 when I got the MACE. So being that age, everybody's experienced it, right? Being a kid is really hard. And I was being made fun of. I was being bullied. I didn't have a lot of friends. I came home crying every day because I was having accidents. I was in a pull-up. I was in a diaper. And the thing that I've taken away from that is I got this done at the age of 10. If I could have gotten it done at the age of 5, when people are typically, potty training, I think that would have made a huge difference, but it just wasn't available for me. So the one thing that I can drive home to people is the earlier you start, the better outcome you are going to have for social implications, for those relationships that you're going to have as an adult, and romantic relationships, for employment, for education. It's the things that, you don't want to be going to work and have to worry about having an accident. You don't want to have to be going to school and having that extra worry to have an accident. If you can do bowel management early enough, that's the thing that's going to create independence. And that's the main goal that we're all trying to shoot for. We don't want to see people not be independent just because of the lack of bowel management and bladder management. So this is a really great comprehensive list of all of the adult clinics available. And this is also going to be given to you guys. So you don't have to copy anything down, and you don't have to worry about that right now. But these are all of the clinics that are currently available within the United States, and these all treat adults.
I think before we go to the very last slide, Courtney, we have some time left and there's been some questions that have come through.
Sure.
So maybe between Joy, you and I, we can try to get some of these off.
Yeah.
So let's see. There was one where somebody was discussing the correlation between bowels and the urinary tract and UTIs, which I know, Joy, you started to talk about. Do you want to add anything more to that?
Yeah. So I think, one of the things that I've found is that when my patients are pretty backed up with stool and they're constipated and they're not emptying their colon regularly, that they are at higher risk for UTIs. And again, this can happen also. I think it can happen during when you have bowel changes, around the time of a period. If it's cyclical or monthly, that can occur because maybe you have looser stool that's, leaking and things like that, that just causes, it depends, if it's much more likely in a female than in a male. And we know, that we are just as females much higher risk for UTIs. So the solution to pollution is dilution. We also want you drinking lots of water, but then people feel like they have to cath more frequently if they drink water. So I usually recommend, if you're going to drink water, get your 12 to 16 ounces in an hour before you're planning to cath. And that's going to make a lot of dilute urine, and it's going to get rid of some of that bacteria. You're going to really just kind of rinse your bladder out from the inside. Any other thoughts from you, Mary Ellen?
I was just going to echo largely what you said. I know when I was in training, I was told that E. coli, which we know is a key player in many urinary tract infections for individuals, E. coli in your bladder doubles in quantity approximately once every 20 minutes, which is incredibly quickly. So you can see how having, a residual amount of urine after you catheterize or something like that is going to predispose you to having a high enough amount of bacteria that you end up with an infection. The same is true in the bowel. And because of that, the close proximity, not just on the outside of us, but inside our bodies, the bladder and the bowel, they're terrible neighbors. And the bowel is kind of it's the physical contents, right? It's like the real hard stuff, and the pee is liquid. So the physical stuff pushes the pee out of the way. They don't make good neighbors in the pelvis, but they are in contact. And because of that, we have realized recently that we call crosstalk. There is basically a communication between the bladder and the bowel. So bacteria can translate from one surface to the other, on the inside as well. So if you are someone who is constipated or practices what we refer to as controlled constipation, where you keep yourself constipated so you don't have an accident, that's going to increase your risk of urinary tract infections because you're increasing the bacterial load in the stool as well.
I think Lauren had a really good question for one of the slides that I had about mushy, creamy stool. And Lauren, I agree with you. As an adult, it may, especially if you are moving around a lot and you have a lot more, that's something that we need to update in our group as well. That I do think it's helpful to have a stool that's a little bit more formed so that you have less likelihood of having leakage of stool. But we don't want it to be hard. That is the bottom line. We really don't want you to have hard stool. So that's a really good question. And I think we'll think about updating that a little bit.
I just want to chime in here really quick with the control, what we label as controlled constipation. So let's talk about that for a quick second if we can. I am a child of the 80s and 90s. That was our bowel management for so long, right? And that leads to so many issues as you become an adult. It leads to stretched out colons that can lead to megacolon, that can lead to so many different things, right? And that is not, if that's the bowel management program that you're currently doing, I just want to the masses that are here, I just really want to reiterate, please, there's other options and there's other things that we can do to try and help that, because it's just not the way. It causes so many issues down the line that I just think are so preventable.
I'll add to that too. We know, again, this is partially all of our faults from the clinician side too. But it can make it really hard, I think, to make a change into one of these other programs because perhaps you're not having accidents right now. So why change that? Um, but trying to do blocking off a few days of life if possible, which I know is hard, and then doing a good bowel clean out that somebody has given you good instructions on before you try an enema program is really helpful. If you just try to jump into an enema program without doing that clean out, it's going to hurt.
It's going to be miserable for you.
It's not going to work. It's going to be really frustrating that you started that. You're going to yell at us. So that's one of the things. I know there was something that came up, and I'll go back to the questions in a moment, but this triggered something in my head. Here where Joy went through our list of interventions, there are stars on these top three. That's because we've done studies using the National Spina Bifida Patient Registry, which has information on over 10,000 individuals with spina bifida in the United States now. And we know that these three things tend to not work very well. So the oral medications only works for about 16% of individuals with neurogenic bowel. So we often will get stuck trying one of these three or kind of in a loop. And we say, if they're not working, move on. They don't work for most individuals, especially if you're someone, you guys know your bodies. If you are somebody who has a more relaxed or open anus, open anal sphincters, easily relaxable, however you want to describe it. But if contents fall out easily and you are more prone to incontinence, we know that these three things are not going to work well for you. They are better for individuals who have still a tight sphincter and retained some reflex of their rectum to that stretch receptor. So those work well if you're one of those individuals. Tight rectal sphincter still has some sensation of fullness and needing to go. These can work well. But if you are one of the many who doesn't fall into that category, we're trying to get people to move away from staying in that category too long of trying that. Okay. There's a question about how the MACE works. I know we talked about it briefly, but do we think we need to do a little more there? Are we good?
I think it's hard because we don't have a picture of one.
Right.
But
we'll pick it up next
so I
week.
think the difference is that instead of using a device that connects into this little tube, you're passing a catheter and you're giving the fluid, which I don't think I said. You're giving the fluid that you would normally give from below through an enema. You're giving that fluid from above so that you're getting the fluid into the ascending colon, transverse colon, descending colon, and out. And that works really well for a number of our patients.
Right. Here we got
I'm
some
just
other
gonna
good.
jump.
Go
I'm
ahead,
gonna
Jo.
jump in super fast there. I think it was related to the same. The same person was also just noting that they had their appendix removed. Does this
Yes.
impact anything?
It can, but it depends on the surgical service. So some of our surgeons have found ways to use other parts of the bowel to tubularize so that you can do that.
It doesn't cross it off the list for you, but I'd say as an adult, it is harder to find surgeons who will do MACEs and ACEs.
Yeah.
Somebody here mentioned, I think, a really good point about working remotely with clinics. Yes and no. So I'll bring up again the adult clinics. You know, they're not everywhere. When I was writing out this list, I noticed they're really clustered in certain areas of the country, and there is some vast areas with nothing nearby. If you can call one that's semi close to you, or maybe near a friend that you might travel to once or once every year, every 2 years, in many of these sites, if you can establish with the clinic, they might be open to doing remote visits with you for up to 2 years after that in-person appointment. That's usually how a lot of the insurance companies are working now, but it is forever changing. So it could be different. So before you go and bet on that and buy a flight to Salt Lake City, call the clinic, see if that's something they would be open to doing. But that has been an option I know for some of the people who come out to our clinic. They'll come, they'll establish, and then we can tweak things remotely on and off.
And Mary Ellen, the
Yes.
National Resource Center can help with contacts at these clinics if that would be helpful to anyone.
There was another question by Lauren. For suppositories, is there a special kind people with spina bifida use? And I would say the liquid one is called Enemeez, Enemeez, also available through Amazon. You can buy them. Not all insurances cover this. And so that is one that a lot of my patients will use. And there's so many questions going on that I lost you now. The rest of, I think there's,
Joy,
yes,
I just want to chime in here for a second.
please do.
If you use the enemies, you can actually, to save on cost, what many people do is buy a gallon of glycerin on Amazon and then refill those bulbs, and that's how we kind of can cut the cost on getting enemies.
And Joy, that was me. I think I moved the question over. So the
Okay.
question was, yeah, so it said, so the question was for suppositories, is there a special kind people use, people with SB use? And because I tried using one once for a colonoscopy and it wouldn't stay in even when I laid on my side.
Right. So the bullet ones that are, hard, they usually come right out. So the liquid ones are much better typically. But I would say they also require, you to be laying in a specific position. Sometimes a lot of people just squirt it in, and Enemies is actually docusate, correct? So it's a combination of both. I think there is some glycerin in it. So there's two types of actions with that, but I think it's, if it works for you, it works, but for some people it doesn't work at all. So it's really a trial and error thing. I think the best thing you could probably do is try some liquid glycerin enema, suppositories first and see if they work. And then if you're getting a little success with that, then maybe consider buying a one package. I think they come in a jar, the enemies for some reason, right? They come in a jar, and you just, you could buy a jar of those and try those every night after dinner for a month and have a seat on the toilet for a half an hour and see if anything works. It might be a good option.
Somebody mentions that they're having a rectal prolapse surgery coming up, a second surgery, and it sounds like their colorectal surgeon is trying to recommend a colostomy. And they're talking about whether or not Peristeen may be a good option. I think that's a very specific question. I'll try to answer it vaguely, not knowing exactly all the pieces there. But generally, using a Peristeen or a Navina, one of those transanal irrigation devices, is actually contraindicated if you've recently had bowel surgery, because it does increase your risk of a complication or a perforation. So that might be part of the problem. Also, again, insurance would be something I would look into. If you're able to get a transanal irrigation device covered by insurance, then that is definitely something you can look into more. Colostomies, as Joy, I think, did a great job saying, a lot of people who get them wish they had gotten them sooner. That is probably the number one comment I hear from adults is, man, I was told this was going to be, so life-changing and kind of the end of the line. but they're like, I wish I had cut to this when I was a teenager or when I was in my 20s. So it might be a really good option. Again, I don't know all the particulars of your situation, but just things to consider.
And I also work with a colorectal team, and prolapses are really challenging, especially when they keep recurring. And so it's, we want to restore as much normal function to the bowel as possible, but it may be that you don't want a third surgery for a prolapse. That's really what I would be avoiding at all costs. And having a per rectum program might be part of that problem. So I would really take very carefully into consideration what your colorectal surgeon is advising. He has a lot of experience, I'm sure, in this area.
Somebody talks about tightening the rectal sphincters and improving peristalsis. Currently, there are no real validated true tests about this on how to do this unless you have an intact nervous system, which inherently, by having spina bifida, that doesn't exist generally. So there are not like pelvic floor PT and such. People will offer it, but I would say the success rates are extremely low. Joy, do you have a different experience, or Courtney?
I would agree. I would say there is a test to assess the sphincter called an anorectal manometry test that's done typically by the GI team. And I think somebody also asked about urodynamics and whether or not that is doing, assessing the rectum. The only thing it's assessing is the pressure that's being in that part of your body that may be putting pressure on your bladder. And so that's just a part of a test that helps us remove outside pressure that we're seeing on the test that's affecting your bladder that might be coming from your colon. So anyway, all that to say, there are tests to do this, to assess it, but I don't know of anything that would be used to tighten that area, or to change the peristalsis.
So something that also, anecdotally speaking, I have seen if you're a woman and you do have sensation, even a little bit, I have myself been to pelvic floor therapy, and it was beneficial for me due to where my lesion is for the spina bifida. So I think that it's also really important to, if you are being offered those particular, interventions, try them. Don't just say, oh, because I don't have feeling, it might not matter. It could. I learned very different ways to breathe during, my MACE, or I learned, but again, if your nervous system isn't intact and it's not there, there's going to be signals that are not there, and it's not, but I want everybody to be able to have, options available to them. And if they are offered, try it. It might not be for you, but it could work.